We'd like to start off with the land and an ancestral acknowledgement. We are grateful to be working on this land. We honor Indigenous peoples, their knowledges, their resources, and their ancestors on the unceded and unsurrendered territory of the Mississaugas of Credit, land of the Anishinaabe, Haudenosaunee, and Wendat people. Also, we honor the Mi'kmaq ancestral unceded territory of Mi'kmaq people in Nova Scotia. We honor our ancestors of African descent who are intrinsically linked to the land and who fought for their survival. Their lessons and sacrifices have led us to gather here today. We ask you to take a minute to reflect and honor our ancestors, those who have now journeyed, who provide the footprints on which we stand today. Feel free to say their name out loud, write it on the chat, or say it to yourselves. Joan Green.
So thank you, Roberta, for that land acknowledgement, and welcome everyone. Thank you to our panelists and the audience members who are joining us today. So COVID-19 has increased the impact of anti-Black racism and colonial violence in our local and our global communities. In Canada, the devastating health disparities among Black populations intersect with historical and current socio-political and economic issues facing Black communities. This forum, Black Health Matters, Responding to COVID-19, brings together an enlightening and engaging discussion about the ways in which the ongoing response to testing, treatment, and recovery of COVID-19 is critically connected to anti-Black racism. In order to discuss the historical resonance of Black health in Canada, I'd like to now turn it over to my co-host, Dr. Roberta Timothy, who is an assistant professor at the Dalla Lana School of Public Health at the University of Toronto. Dr. Timothy has worked for over 25 years in frontline community health sectors, in shelters, community health centers, hospitals, and private practice, specializing in the areas of intersectionality, decolonizing health and health violence, Black health, ethics in health, transnational Indigenous health, health justice reparations, and anti-oppression and anti-colonial approaches to mental health. Thank you, Roberta.
Thanks, Ray. People of African ancestry in Canada have a history of colonial violence that started in villages throughout the African region, as families were brutally torn apart, separated forever on the shores of Cape Coast dungeons in Ghana and other African enslavement ports, that through the Middle Passage and forced migration to the Caribbean, Latin and South America, Europe, the United States, and Canada, to name a few, made up the transatlantic slave trade. Black folks that survived were then bought as property, and generations worked with no pay and with daily experiences of sexual, physical, mental, spiritual, and financial violence. The transgenerational health and trauma impacts of such brutality impacts Black health today. Olivia Lejeune, a young Black child from Madagascar, was said to be the first enslaved African in Canada, in the British colony, in 1632. The Code Noir, an anti-Black racist policy, forcing baptisms and decreed the conversion to Catholicism of enslaved Black people, restricting rights and freedoms. The Code Noir and other Canadian state policies successfully police slavery and Black folks' lives. This directly connects to current day racial profiling, carding, increased incarceration, poverty, and structural violence in the lives of Black people today. The Slavery Abolition Act of 1833 banned enslavement of African people. However, the ideologies, practices, and actions of intersectional colonial violence and anti-Black racism continues to impact the health of Black communities today. The overrepresentation of Canada as a haven for the Underground Railroad does not tell the brutality and violence experienced by African peoples once in Canada, including learned homes, lynchings, rapes, economic and educational sanctions, and other brutalities. We've also resisted, strategized, and fought back in many ways. Black health disparities, or what I call Black health violence in Canada, directly relates to African enslavement and colonization. Continuing forced migration of Black loyalists to Nova Scotia and Southern Ontario, African Caribbean domestic workers' migration to Canada in the 60s, and Africans living in the African continent migration are all due to factors related to colonial violence and historical impact of enslavement of Black people. Black health disparities in Canada include lack of access to appropriate healthcare, experiences of anti-Black racism by healthcare providers, low-paying healthcare jobs such as PSWs, and little power to make decisions about our health. As a result, Black health in Canada before COVID-19 was in a state of emergency. An Ontario study determined that from 2001 to 2012, diabetes rates doubled among Black women from 6% to 12%. Black women have a higher risk of developing cardiovascular disease than Black men. Among ethnic communities, Black women have had the most drastic increase in rates of high blood pressure, increasing from 20% in 2001 to 27% in 2012. 24% of Black Ontarians qualify as so-called low income, as compared to 14.4% of the general racialized Ontario population. In the Toronto District School Board, 69% of Black students graduated in 2011, as compared to 87% of racialized students and 84% of white students. 41% of all children and youth are in care apprehended by the Toronto Children's Aid Society are Black. If you're Black in Halifax, you're 6 times more likely to be carded by police compared to white counterparts. In Vancouver in 2017, 5% of the street checks involve Black individuals, who make up only 1% of the city's population. The United Nations Working Group of Experts on People of African Descent has raised alarms about systemic racism with Canada's justice system. All these factors listed before COVID-19 impact Black health and are directly related to colonial violence and the impact of anti-Black racism. Black health disparities during COVID-19, with little testing in our communities, mistrust in our health systems, lack of rent freeze, overrepresentation of frontline workers, and increased police surveillance, to name a few factors, is devastating our communities in Canada and transnationally. Dr. Rai Reece will now focus on one important aspect of Black health that is often not highlighted: prisoners and health.
Thank you so much, Roberta. So one of the ways in which we see the enacting of anti-Black racism and Black health oppression is in the context of incarceration and the disproportionate numbers of Black folks who are racially profiled and incarcerated. And this is really important to talk about because prisons are a part of our social environment, and oftentimes we don't see them as part of our communities. When it comes to health matters and Black lives, mass incarceration not only takes a toll on Black, Indigenous, and Brown folks, but we see glaring health disparities as well. So I really want to reference Elle Jones here, who is a member of the National Abolition Coalition and also a scholar at St. Mary's. And she says, and I quote, "Incarcerating people during COVID-19 is a human rights disaster," end quote. And I think this is really important because prisoners will be the last folks to receive PPE because the social narrative surrounding their bodies is that they don't matter. We saw reformations of this whenever there's any sort of healthcare or national crisis that takes place in Canada or even in the United States comparably. If the Canadian government can implement decarceration measures, which they have in provincial prisons during COVID-19 by releasing over 1,600 folks who were in provincial jails, then those folks likely did not need to be there in the first place, right? But that also means that when folks are released, that means that they become vulnerable around food and housing security, access to healthcare, and mental health support. So again, the impact of COVID-19 is far-reaching and viscerally impacts Black bodies. So we really need to think about the use value of incarceration as a social safety measure in our society. Prison health is public health, and this means talking about anti-Black racism as intersectionally connected to mental health, transphobia, homophobia, racial profiling, the school to prison pipeline, access to adequate healthcare, and literally a reliance on a social welfare state that has been based on oppression and maintained by power and white supremacy. Many of these issues have been present, as Dr. Timothy has mentioned, for Black folks well before COVID and well before incarceration, and incarceration exacerbates many of these issues. The unprecedented crisis that COVID-19 is really illuminating is what many of us in Black communities have known for years. And this is one of the reasons why we are so excited about this forum. So in order to grapple with this issue and many other issues that highlight the devastating health disparities among Black populations and the workings of anti-Black racism in Canada, we've organized this forum into 4 thematic areas of discussion. The first being racism as a determinant of health. The second, we'll look at race-based data collection and governmental response. The third, we'll look at working while Black, the experiences of service providers And in conclusion, we'd really like to look at and have a discussion around some of the strategies for a collective community response and some of the things that have already been happening in regard to Black health and COVID-19. So now I'm going to turn it back to Roberta to introduce our first segment and our panelists.
Thanks, Ray, and thanks for reminding us that prisoners' health is public health. I also want to introduce you properly because I want to say your bio, I forgot, sorry. Dr. Rai Reece is a professor in the Community Justice Services Program in the Faculty of Social and Community Services at Humber College. Since 2005, she has been involved with anti-prison work with prisoners and ex-prisoners. In 2007, she conducted one of the first research projects in Canada to exclusively examine the intersections of race, incarceration, and the meaning of Canadian citizenship as it pertained to federally sentenced Black women in Canada.
Thank you.
Thank you. We'd like to continue now this discussion and invite our esteemed panelists to share their knowledge, experiences, and advice. Our first segment today is on racism, anti-Black racism as a determinant of health. We know that there's over 1 million CV-19 cases, 150,000 deaths globally, 33,000 cases in Canada, and 1,469 deaths. We'd like to introduce Mercy Gichuki and Dr. Omishere Dryden to speak. I'm just going to introduce them quickly to speak about the determinants of health and how it relates to COVID-19 in Black communities. Mercy Gichuki is a program manager in the VAW sector. Her experiences in both VAW and the public health sector, working with women living with HIV, survivors of gender-based and sexual violence, and newcomers. Dr. Omishere Dryden is the James R. Johnson Chair in Black Canadian Studies in the Faculty of Medicine and an associate professor in the Department of Community Health and Epidemiology at Dalhousie University. Her research is situated in Black Studies, Black Queer Diasporic Analytics, and Black Health Equity. Mercy, we'll start with you, please. Share with us your experience and knowledge in relation to racism as a social determinant of health and how it relates to responding to Black health and CV-19 in Canada. We might be having some tech difficulty. Mercy, are you there? Okay, we might be having a little bit of tech difficulty with Mercy. We're gonna start with Dr. Omishere Dryden, please. Hi.
Hi, how are you? It's lovely to be on the call with everyone and I appreciate it. I don't actually have prepared remarks. I really am thinking about this more of as a conversation. As we know, the social determinants of health look at income and social status, employment and working conditions, education and literacy, childhood experiences, physical environment, social supports, coping skills, healthy behaviors, access to health services, gender, culture, and race, depending on the list you're looking at, or racism if you're looking at some more progressive lists. And so one of the reasons I've argued, actually just recently, around the importance of considering social determinants of health in COVID-19 pandemic responses is I believe we should think about the ways in which these social positionings also impact our access to health. After all, that's why we have the social determinants of health. The social determinants of health kind of push us to think outside of the biomedical and look in the cultural and social and see how those aspects impact our life and therefore impact our health. And so that means looking at poverty, being underhoused, having precarious employment, working more than one job if employed, being homeless, being without homes, being drug involved, being a drug user, working in the gray economy and the underground economy, as well as misogyny, homophobia, and racism. And so when I think about these pieces and when we do this work, the reason why it's important to look at, for example, how racism impacts our health is because of the kind of physiological impacts racism can have on our bodies, right? And so racism can make it, the effects of racism can make it harder to heal. The effects of racism means that it exacerbates increasing chronic conditions, right? These are medical measures. Although we, what we're hearing across the country right now is that it's colorblind, that, we treat everyone the same, that we actually don't need to think about the social determinants of health because right now we're in a pandemic and there are more important things to look at. So what I propose is that we consider this, the social determinants of health as also an aspect, a cultural and social aspect that we can consider comorbidities, right? And what this does is it shifts the look away from, for example, race, right? So in some lists of social determinants of health, there's this, they say race, and then they do this type of race biology, where it's like, oh, if you're Black, then, and you have pain, then it must be sickle cell. And I'm not saying that there aren't many members in our community, right, that live with sickle cell, but it's become racialized in a way that it forecloses lots of other pieces that could happen. So if we think about the social and cultural aspects of social determinants of health as comorbidities, then we can think, I believe it offers us a way to better understand the vulnerabilities that we are exposed to. So it's not just the biomedical comorbidities, but then that is exacerbated by the fact that we deal with systemic racism on a day-to-day basis, that we deal with being underhoused, that we deal with, precarious employment, that we may live in communities that don't have access to clean water, or we may live in communities that are in food deserts, and that all of these things can increases our vulnerability to contracting, right? Being in spaces where we come into contact with the virus, but then having greater difficulties from being treated for the virus. So if we live in these challenging spaces because of the social determinants of health, it means then that we also don't have access to physicians. We don't have access to health services. It means that the kind of public health hammer on how information is shared isn't necessarily tailored to how we assess information or what reflects how we're living our own lives. And this is where I think we need to be a little more critical or a little more thoughtful around the normative ways that public health has even spoken in some cases around COVID-19, the pandemic, and these broad strokes of stay home, social and physically distance yourselves, wash your hands repeatedly, only go to groceries once a week. And if you don't do any of that, we'll ticket you and arrest you and stigmatize you. So I'm hoping those are some useful seeds to think about.
Thank you so much, Dr. Dryden, for sharing. Your analysis and experience are critical for understanding the COVID-19 or lack of responses based on racism as a social determinant of health. I'd like to ask Mercy to share your thoughts, please.
Thank you, Roberta. I'm online now.
Yes.
So I wanted to look at gender-based violence as a burden of disease and how it impacts and how it's related to health. A lot of the times we don't associate gender-based violence in relation to health concerns. So we all know that around the world, long before the coronavirus came into play, gender-based violence is already a pandemic in itself. And right now, with all the lockdown to stop the spread of the coronavirus to save lives, women and children who live with domestic violence have no place to run to. We recognize that the shelter systems are overcrowding right now. We know that we are not seeing a lot of people going to emergency. We know that people are not calling the police. The calls the online crisis calls have gone down just because people are not in a position to be calling. We also know that frontline workers are concerned with the rise of abuse and looking at how the shrinking of economy and how all the jobs that women work in are dependent. All the jobs that women work in, most of them are closing down, and now they have to be also financially dependent on their partners and how that is looking like in their homes. So according to the Center for Global Development has identified 9 ways in which the consequences of the response to the corona pandemic is increasing VAW violence, which is including economic insecurity and poverty-related stress, quarantine and isolation, social isolation, exposure to exploitative relationships due to changing demographic, reduced health services availability and access to fast responders, virus-specific sources of violence, inability of women to temporarily escape abusive partners, exposure to violence and coercion response efforts, and violence perpetrated against healthcare workers. We know that when women go through gender-based violence, some of the things that they have to go through includes injury, self-harm, depression, unwanted pregnancies, which all, come together as health concerns. We also are aware that isolation is not helping at all. So as much as it's good on the one hand in the spreading of the coronavirus, it's not doing any favors to women who are not in a position to raise the alarm that they're going through violence. You know that if you're coming out and you're wearing your PPEs, and if it was physical violence, then it's hiding any telltale bruises. Children are not going to school, so if there was any opportunity for looking at any telltale signs, those opportunities are not there anymore as we speak, right? So we took a few results on the police report. So we looked at York Region Police to see the incidences that have been reported since COVID-19, including domestic incidences, and we see that they grew by 22% in the last 30 days. Officers had responded to nearly 700 domestic incidents. In York Region, domestic-related calls had increased by 14% year-to-date, and there was a 2% increase in the month of March. We're seeing sexual assault calls also increased by 22%. In Field Region, there were 1,021 intimate partner occurrences between March 1st to April 6th. And in Toronto, they're seeing drops in numbers. So my biggest concern is that in the Black community, a lot of people do not depend on the police. They don't feel comfortable in calling and asking the police to come and do interventions. So what I do believe is that we are not seeing as many reported cases coming out, and the concern right now is how will this look like when COVID-19 passes, and what measures are being put into place to make sure that currently that there's support being put in place for the women in the community as we speak, and also long after COVID-19 passes, because we will be seeing a lot of increase in mental health needs, and how are we responding to that. So I also want to highlight that we have a lot of workers working in the PSW sector. So we know that women account for a majority of frontline healthcare workers who are bearing the brunt of the crisis as they interact with the infected and care for the most vulnerable. And we know that PSWs are the most precarious in this case. So we have 70 to 80 of primary healthcare providers are women. And in Canada, just like in any other first world countries such as the US, Denmark, France, Netherlands, Australia, 96% of women work as PSW workers. In Ontario, we're looking at self-identified PSW workers as 42% of them identified as Black, 14% as Filipino, 4% as 3% as Latin American, 1% as South Asian. And we're seeing in nursing homes that there's shortages of PPEs, in shelters there's shortages of PPEs. And these are the vulnerable community members that we have who are working in these sectors, and they don't even have the proper equipment to be working and to be protecting themselves. We also know that with all these laid off and people, we have a lot of people who work under the table, people without starters, migrants and newcomers, who will not be able to apply for the funding that is coming out. And as we speak, I know of several people who are still continuing to work and put themselves at risk because they have no other ways of earning any income or getting any money coming into them. So we do have a lot of vulnerable people there. So in terms of moving forward, we're looking at actions to how do we come up with actions to make sure that women and children are safer during this pandemic. I am aware of still coming up with a campaign. It's not out there yet, but hopefully that it can reach out to women who have no social technology to reach out to ask for help. And we are asking folks, to check in with their family members, with their friends, to make sure that they are okay. And if they're not okay, to look for ways to make sure that they can get help as soon as possible, because then that's the only way we can reduce homicide rising. Thank you, Roberta.
Thanks, Mercy, for sharing some really important points, bringing up the impact of gender violence, the impact of the division of gendered labor, and anti-race and racism, and how it impacts COVID-19, our Black communities in the COVID-19 pandemic. What we would like to do now is we'd like to just ask some of the viewers if you have any questions pertaining to racism as a determinant of health and COVID-19 responses to Black community and Black health, and we can share those questions and answers with the panelists.
So we have a number of questions from viewers, so thank you so much. So I'll just pull from a few. There actually are 13 questions and we won't be able to get to all the questions. So I think what we'll do is we will provide answers via a link or an email for folks if we don't get to your question, but we do appreciate them. So one of the questions to begin with, the first question was, and this is for Dr. Dryden or Mercy, what is a more culturally appropriate way to impart public health messages if we understand that public health actions need to be coordinated?
Right, thank you. Yes, I saw that question. It's a great question. So one of the suggestions I've been making in Nova Scotia was because of the historical, not just in Nova Scotia, but because of the historical experiences that Black people have had in Canada, and the ways in which medical racism has played itself out in and through Black communities in Canada. What that does is it sows a lot of suspicion and resistance to governmental health processes. And so I think people like to say that, Canada is better than the United States. And I think all of us here understand that that is not the case, that it is different, yet still racist. And I think some people will say, well, that's a long time ago. We shouldn't be focusing on that right now. But if we really take seriously the work of Saidiya Hartman and others, the afterlife of slavery is absolutely manifesting itself in our day-to-day life. And we see that afterlife of slavery, that continued systemic racism, through the fact that we don't have, adequate access to health services, that, when we do go to emergency rooms, we wait longer, that whenever we are often pathologized as drug seeking when we're looking for pain relief, that we're often disbelieved when we go in and we say something's happening and they're like, they'll send us home. We've all heard those stories and seen them in the Canadian press of people who have died after just leaving the hospital or, died in the waiting room. We've seen that with Black and Indigenous people across this country. And so if we look at the history of African Nova Scotians in Canada, the oldest communities of Black people in Canada are in Nova Scotia. And so if we think about just the ways that Nova Scotia, the government has been with African Nova Scotians, erasing Africville instead of providing services, right? We're gonna throw you out instead of providing the services that you need. Of course, there continues to be an understanding that these long-standing racist systems continue to disadvantage Black people in Nova Scotia and across the country. So when it comes to something like public health, what we need to do is think proactively. So proactively means working with local community members, working with Black people, to go in, to go door to door, to knock on doors, to work with churches. Churches are a huge center in various communities throughout Nova Scotia. It means working with the kinds of resources that would help support communities that are traditionally vulnerable. So we are precariously employed. We can't simply stay home. We have to be able to provide services that allow us to work our 3 or 5 or 6 jobs while keeping us healthy so we don't contract the virus. But if we do, by not then stigmatizing us because we contracted the virus, right? And so the way that racism plays out in health now is that Black people end up being responsible for the fact that we got sick, and then Black people end up being responsible for the fact that we died, right? And systemic racism and the stigma of racism will absolutely cause our death in COVID through this pandemic. And that's why we need to vigorously, rigorously demand better from the government, but also work collectively with ourselves to provide the services we need.
Well said. Well said. Thank you so much, Dr. Dryden. We have a number of questions. I want to ask that. I think this is a really important conversation, and just being mindful of our time. There is a lot of folks are asking questions around race-based status. So just to address those questions, that will be answered in the next segment. But for now, just a segue from what Dr. Dryden just said, someone's asking, what are we doing as a community to support and bring awareness to the reality of frontline workers during COVID-19, especially PSWs? How can we come together as a Black community to support PSWs? And I just want to also add on to this question. Many of you have probably heard the discussion or the narrative that Premier Ford said the other day about people shouldn't be working 2 jobs, and that's contributing to the spreading of the virus, right? And so that comment in and of itself completely negates, dismisses the very lived reality that many racialized folks have when they work multiple jobs to survive, right? So I just want to put that question out there. Perhaps, Mercy, you can speak to that in terms of the disproportionate number of PSWs and frontline workers who are working during this pandemic.
That is I know that is one of the biggest challenges, and especially that, people have to work from one and move to the next job, yet they're being told that they may have to stop working in one of their work, and yet there are no measures that are being put in place. So what I do know is that if we're sitting in any round tables, is for us to raise these concerns and try and find out how we can best support them. Okay.
Oh, that's okay. That's okay.
Listen, that's how Black things work.
Yeah.
That's okay.
I am so sorry.
No need to apologize.
No.
So yes.
It's the triple work that we're doing.
So as I'm saying that, so the challenge is that even with the money that the government is flowing down, I don't think it's going to be reaching some of these people. So for me, it's for all the tables that we are sitting in, for all the tables that we have opportunities to sit at, it's for us to bring our agenda to these tables, because I find that the conversations taking place and not having the Black community at the table, right? Who's sitting at these tables, who's having these conversations? How is this distribution of funding that is coming from top down going to look like, right? And making sure that if and when it reaches, that it's going to spread evenly and people can get those dollars. Thank you.
Absolutely, thank you.
So thank you, Mercy, for sharing and answering the questions, and Dr. Rai Dryden for sharing some important questions about racism as a determinant of health and other factors, intersectional factors that impact Black folks in COVID-19. We'd like to move right on to the second segment, which is going to be on race data and government response. So I'll take it back to you, Rai.
Thank you so much. So just before we begin, I want to know, because there are quite a number of questions, we will compile all of the questions and provide answers, feedback from our panelists, and we will get that out to folks. So thank you so much. I just don't want folks to feel like we're not responding to some of their very important questions. So thank you. So in terms of the numbers, many of you have asked about race-based data collection and the governmental response. And so it's really an honor for me to introduce our next panelist. And Beverly Bain is somebody that I've known for many years and has been on the front lines of activist work in our community. So she's a professor of women, gender, and sexuality studies in the Department of Historical Studies at the University of Toronto, the Mississauga campus. She is a Black, queer, feminist, anti-racist scholar activist. Her area of teaching and research is in Black, queer, diasporic sexualities, gendered police violence, and post-colonial studies. She is currently working on a series of essays on Black, queer, radical feminist organizing in Canada. So Bev, I'm gonna turn it over to you and ask you to speak about race-based data collection and the governmental response, and also about policing and surveillance.
Okay. What I've done, because I am not sort of a specialist in health data, what I've done is just formulated a statement here in terms of how I understand data at the intersection of the responses, but also, at the intersection of, the impact on Black lives. So I'm just going to read that statement, okay? The Ontario government and David Williams, Ontario Chief Medical Officer, are deeply deceitful by insisting that we do not need data on race because we are all equally important. The call for race data as a challenge, the call for race data, as a colleague reminded me today, should be understood as a call for justice. It is a way to make visible and our lives and health status during this pandemic. In other words, it's not a call for the state to further regulate our lives using this data. It is not an invitation to the province to permit police to randomly administer COVID testing to individuals on the street who they deem, from appearance, are possibly vectors of this disease. Because what we know and what we're hearing right now is that in Waterloo, the police has, the government has given the police permission to actually administer testing for COVID virus. So when a police stops you on the street, if for some reason you look like you are infected, I'm not sure what that look would be like. Clearly it would be Black, it would be brown, it would be homeless. It would be somebody who's a sex trade worker, an Indigenous person. They would be administered a COVID test to see whether they are carrying the disease. And that would be stored in their system. So one of the things that we are concerned of, and I am concerned about, is when police actually administer information that they collect as data, what happens with that information? And where does that go, and what impact that has on the lives of those of us who are Black and racialized and Indigenous in public spaces. And we know historically that what it has done is that it has been used in particular ways that have been regulatory, that have been for purposes of surveillance. So for us, it's really important who collects that data, what happens to that data, where that data goes. And clearly, part and parcel of this work is advocating for data that is used in the context where justice is fundamental in terms of how it works to care for Black lives. The call for race data is a way to track the current health conditions for Black people in this current context under COVID-19, who have historically been located at the margins. at all socioeconomic levels because of the legacy of slavery, anti-Black racism, and poverty. Black women and other racialized women make up the bulk of those on the front line, working as PSWs, cleaners, nurses, cashiers, and grocery, etc. And we've been hearing that earlier today. They have been working in a context where PPEs have been hard to come by. So we know many have been exposed to this virus. There is no question that we know that some of our Black frontline workers have been exposed. Some of them are actually in peril at this point. So a call for race data is a call for justice for Black people during a time when our lives have completely disappeared from the Canadian landscape, even though Black women in particular are on the front lines protecting and caring for others. The nation has always pretended we and those who are racialized do not exist, particularly in times when the protection of the nation and citizenship seems at risk. It is in times like this that the nation immediately coalesces around visuals and narratives that are white, while invoking mantras like the famous, "We are all in this together." Yes? But what we are seeing, clearly, visually, we are seeing who are the heroes, who are on the front lines, who are risking their lives, who are dying, and who must be saved. But we're not seeing or hearing about the lives of Black, brown, racialized, indigenous people as people who are actually in peril, who are actually working to protect others. We have numerous kinds of projects that are taking place that are run by Black and brown people as ways to protect each other. We're not hearing of any of those stories. The stories that we are hearing are stories that coalesce around a white narrative. Right? So therefore, the lives of Black and brown people disappears, get subverted, and are put even more at risk in this context. So the state has chosen to invoke hyper-policing, actually, tactics that include street checks, ticketing, carding, snitch lines, all of which have already seriously affected the lives of Black people. We have heard of stories of situations of families in the park who have actually been accosted and beaten up by the police. We have heard of Black people in other provinces being accosted, harassed, ticketed. A homeless Black man being ticketed. Someone here in Toronto downtown being corralled and run over, by a couple of cruisers. So we are seeing the impact of not recognizing Black lives in this country, and not recognizing that Black lives are at risk, at further risk. We're also at risk from the police. How are we to know that the police themselves are not infected when they actually approaches us, when they actually corrals us, when they actually arrest us, that they too are actually putting our life at risk through the actual act of policing. Therefore, in thinking of data collection, and I know we all on this page, is that we're thinking of data collection in a way that actually works to protect our lives, work to recognize, pre-existing conditions that are tied to racism, that are tied to colonialism, that are tied to capitalism, that are tied to, ongoing neoliberal and the colonial project. And that we want that very clear, and that those kinds of information are actually coordinated in ways where particular people who are experts in the field, and that is primarily Black, and racialized experts in the field of health are in control of that data and in control of that information. Thank you.
Mm-hmm. Thank you so much, Beverly. That in and of itself could be a separate Zoom forum. Absolutely, many of the things you've talked about, just absolutely critical and phenomenal. We are getting an enormous amount of questions. And so before I turn it back over to my co-host, I just want to quickly mention a letter that was sent on April the 15th by Black health leaders who work at community health centers. And I think this is a really important collective statement. And it was sent to the Chief Medical Officer of Health, Dr. David Williams, as well as the Deputy Premier and Minister of Health, the Honorable Christine Elliott. And so I just pulled out 3 key points that I felt were really germane to our conversation today. And this is that in 2016, a report was issued by the UN Working Group experts of people on African descent on its mission to Canada, and found that, and I quote, "a lack of race-based data and research that's not available impedes prevention, intervention, and strategies to protect the human rights of African Canadians," end quote. In 2017, the Ontario Anti-Black Racism Strategy wrote, and I quote, "the impact and consequences of our history have created systemic barriers that prevent people from fully participating in all parts of society," end quote. And lastly, in 2017, the Black Experiences in Healthcare Symposium, exploring health inequities faced by Black Ontarians, identified the need for systemic change and named race-based data collection as an important facet of this work. So I believe that all of these pieces in connection and in conjunction with what Beverly has said are really and critically important. So I'm going to turn it back over to Roberta to take some questions from our audience.
Thank you, Ray. Thanks, Bev, for talking about the importance of looking at race-based data and looking at the intersectional impact, looking at police surveillance and other factors. So we have many questions here. I pulled 3 questions that we're going to try to answer in this next segment. The first question, a lot of discussion is coming out of the US, where data shows that Black individuals are disproportionately impacted by COVID-19. When I have this discussion with family or friends, their immediate response is Canada is not as bad as the US. What are your thoughts on this?
Is that for me?
Yes, Beth, that's for you.
And again, this is why I made the statement I did.
Yeah.
The critical thing is that there's always this, the way in which the nation state constructs itself is always to construct Black life as somewhere else and not here. So what is happening, so Black life is not present in the nation state. And any time we talk about Black lives in peril, Black lives at stake, we always point to what's happening in the US, because the obvious data and the obvious context of the US makes that possible. But the reality is that there is no question that we have seen over the course of decades how Black lives are in peril through policing and hyper-surveillance. The deaths of Black people in this country at the hands of police, the issue of carding. I mean, it was in 2019 that the Ontario Human Rights Commission published its report, which clearly stated that Black people are carded, policed, and actually arrested and shot more than anybody else in this country, other than, in connection to Indigenous people, right? Blacks and Indigenous stand at the sort of, within that context of being those imperiled by surveillance and policing and imprisonment and incarceration, right? So that was actually, and then one of the recommendations that came from the Ontario Commission is that, the data on how police engage in stopping and carding and arresting be documented, but that a particular kind of framework be set up that's transparent so that those in the community can oversee that information and ensure that it's not being used to further, the detriment of Black people in this country. Because one of the things that we have to be clear and be open about is that if data is collected, doesn't necessarily mean that people's realities will be resolved if that data is not put to use. Because we can see what's happening in the US. A lot of data is collected, but Black lives have not improved. You know what I mean? Like, let us be clear. So data does not improve life, but what data does do, it opens up and gives us a sense of what is happening to Black people. And then what we do with that data is what becomes important in holding our state or government or officials accountable for not using that data to make our lives better.
Absolutely. Well said. Thank you, Beverly.
Thank you so much, Beverly. And I think that the whole, adding to that is the notion of Canada as the Underground Railroad. Canada doesn't, doesn't have racism or doesn't have bias. We know that that's not true, and we know that that's an excuse. If we look at how it's been covered, even in terms of racism and data collection in the Canadian context, I've seen national media, focus until recently on American news, and it was like it's out of there, out of sight, out of mind, and not focusing on the real responsibility of anti-Black racism in Canada. So thank you for that answer. The second question I actually want to read the next two questions, and because I think they connect to each other. They are: has anyone thought to use the Human Rights Code in the Canadian Charter options to demand race-based statistics? The federal contractors program actually requires that these statistics be kept in order to receive funding. Why are these not being relied upon to get work moving? And the second question that I think we can really put together is: the Anti-Racism Act of 2017 legislates the government to collect race-based data. The question is, how is the government now following through on their legal obligations? And I think these are really important questions to look at. Can we actually make changes through policies and legacies in government when these policies and legacies are inherently anti-Black racist and have not supported Black communities in terms of health? Bev?
You want me to answer that? Okay. You know what? I'm sorry, but I'm having some problems hearing. I don't know if it's my computer or if it's the internet, but I'm having some problems hearing some things.
You want me to read the question again?
Can you? Because I didn't really get it. Thanks.
Has anyone thought to use the local Human Rights Code and Canadian Charter options to demand race-based statistics? The federal contractors program actually requires that these statistics be kept in order to receive funding. Why are these not being relied upon to get the work moving? And also the second question is about the Anti-Racism Act of 2017, which legislates the government to collect race-based data. The question is, how is the government now following through on their legal obligations? Basically, can
I think what we have found is that the government has been asked to collect race-based data in particular ways, not on an overall level. Right. So for instance, I think we know that race-based statistics are collected in labor, right? That's allowed. Right. We know that it's collected now. It's collected in terms of, how police now police people. That has been actually here by but this is only recently because of the Ontario Human Rights stipulation. Right? In health, it's still obviously not yet demanded. And the loophole that apparently the minister, the Ontario government, and the Ontario health the health officer is using is that collecting data by race is also a controversial issue. It also can actually somehow infringe upon the Human Rights Code in the context of privacy issues. I mean, this is what they are reverting to, issues of privacy. And the question one has to ask is, whose privacy and privacy for who, right? Mm-hmm. Like, whose privacy are you protecting? When a community is saying to you that because this does not exist, this further imperils life. And you are saying because of privacy issue, and that is part of the Charter of Rights and Freedoms is to protect people's privacy. The question becomes, whose privacy and whose rights are you protecting here?
Thank you, Bev. And I also think it's interesting that they're collecting age-based data and gender-based data. So when we're talking, and race is not being collected. So it's definitely a problematic, it's a failure on the system for sure. And thanks for addressing the questions also. We'd like to thank Bev for talking about race-based data and the government response, and particularly the impact of police surveillance on COVID-19 or on Black health during COVID-19. What we'd like to do now is to go into the third segment, which is entitled Working While Black Service Providers Experience. And I'd like to introduce our honored panelists, Maureen Owino and Dr. Onye Nurum. Marina Reno, since 2007, has been an active organizer and advocate for immigrants, refugees, women, and youth with HIV/AIDS in Toronto. She is currently a member of the Ontario Advisory Committee on HIV/AIDS, OACHA, and a Community Advisory Committee member for the CIHR Canadian HIV Trials Network, CTN. She has a master's degree in environmental studies from York University and is currently a PhD student at York University. Dr. Anya Nuram is a family doctor and a public health and preventative medicine specialist. She's the Associate Program Director of the Public Health and Preventative Medicine Residency Program at the University of Toronto and is the Black Health Theme Lead for the Faculty of Medicine at the University of Toronto. She's the President of the Black Physicians Association of Ontario and the Chronic Disease Prevention Lead at Taibu Community Health Center. Dr. Nuram also hosts a podcast called Race, Health, and Happiness. Maureen, if you could please begin sharing your thoughts and experience with us.
Oh, hi everyone.
Hi, how are you? How are you doing?
Yeah, working while Black. Yeah. So, and I think just on top of my mind, for me to be on this panel, I had to really think about what role I want to sit on this panel as a Black woman who has a lot of roles and what I want to identify with, and just a disclaimer. And I chose to be on this panel as a university student, because being a university student is a disclaimer. So anything I say is me as a York PhD student and not in any of my other roles. So, and that is just the complexity of working while Black. It's about navigating tight ropes and navigating roles in spaces where you see oppression and you see violence against people who you call friends, who you call peers, and you call out these people and yet under we cry. And sometimes it gets used against you. So in the context of COVID-19, working while Black is a very challenging thing. I've been stressed out over 2 weeks, but like to address some of the questions, and before I go to those questions, in terms of even the race-based data, I just want to bring this up. Beverly, thank you so much. A few weeks ago, Dr. Winston Asman and I also wrote an email to the City of Toronto to ask for race-based data, because without race-based data, we cannot know how to support our communities in response against COVID-19. We are yet to receive any feedback. But realistically, at the beginning of COVID-19, before the whole quarantine, social, physical isolation piece, the CIHR released funding for researchers to apply for funding to support Chinese Canadians in the fight against stigma against COVID-19. I just need you to think about that as we move on with the conversation. So without the race-based data, we can't even access funding to support our communities to do work for our communities. That's just one piece. The second piece is looking in the context of policing a pandemic. We know how policing HIV, policing, just the context of pathogenizing Black people and how the policing of public health issues has been used against Black people. Tuberculosis, syphilis, HIV, and now COVID-19. I live in a place when my son goes out, I'm like, carry your phone and be careful. If you see policemen, call me back. Because I know if there were policemen on my street, he would be the first one to be stopped. And so these are all very important things. But going back to the context of working while Black, the questions that come up, and I've been talking to my friends and my peers and Black people, and last week I realized that I know a lot of Black people who are in essential services. I know a lot of people from my Kenyan community, from my other non-Kenyan communities, who are PSW, who are nurses, who are working in these spaces. And I was thinking, I do know a lot of people in these roles, and they're all out there. But I've also had conversations with people who are nurses and in healthcare telling me, we are not getting PPEs. We are being given 2 masks a day. We are being policed in how we use these masks. I have also had people saying, I can't choose not to work, because choosing to work means I have to disclose a lot of things that I can't disclose. It means that I go to work and I have to go home to my babies and I don't know what I caught there. And choosing not to work means I don't have income. And I think we talked about, Ray talked about also not doing more than one work. We know Doug Ford cut out the income rates, yeah? So people who work in PSW work multiple locations. I work in a health center. I have friends in the health center who work multiple jobs. They can't anymore, but they cannot access the CRB. I've been talking to people about job security. It's unfortunate, very unfortunate, that I have friends who got laid off. I got friends and chosen family who were laid off in Black organizations when nobody asked for layoffs, when they are home now without jobs. And I've had to step down. I've had my voice shut down because I spent days screaming that we need resources for Black people. I can never scream we need resources for Black people when Black people lay off Black people. I can never do that again. So my voice has been shut down. I do not have that voice anymore to advocate for my community because people took that power away from me. But other Black people, what does it mean to lay off a Black person? It means a whole family is losing. There's children, there's family. How many people? I look at the people on the panel with me. I know a lot of you. A lot of you are my friends outside of this panel. I know how many of you have family in nursing homes. I know how many of you have losses, have children who are sick. You're sitting here fighting this battle for the whole community. But there's people who don't care. They don't care. So long as they can sit behind keyboards and say, yeah, we are activists for anti-Black racism, it's nice for them. So long as they can go get food in cans and then go out and say we are contributing food to people when there's 10 families, hundreds of people not getting services because people get laid off. How is it that this COVID-19 is not making it an opportunity to punish people for standing up, to punish those you don't like when you're working there? It's being used as punishment for people. What do we talk about at the end of COVID-19? Who gets recalled? Do I get recalled? I keep speaking in spaces and I've always said, I know I speak out and I know I'm unemployable. Oh, Roberta told me that if she could get employed, I'll get employed. So I'm no longer unemployable. But I speak out. I stand up. And I know there's places I would not go to. I would not speak because, no, they'll never give me a job because I'm always speaking up. But is it worth it for me to sit and see all these people suffering, all these children, all these people being punished? COVID-19 for a lot of Black people has been used as punishment, has been used for people to revenge against some sort of, I don't know, witch hunt. And it's important that we think about that, and especially among Black people. We already deal with racism. We already deal with oppression. What happens if there's funding cuts at the end of this? 4 months from here, who gets employed back? Who gets back into the employment environment? Who gets recalled to employment? We already know most Black people will not be recalled. And that's the reality in wherever areas that is. There's a lot of undocumented people. I'm talking to these women who have no status, who who work under the table, who are working in restaurants, cleaning restaurants and everything. And I'm telling them, you can't go to work. And they're asking me, what will I do? I need to pay my rent. I can't apply for CRB. What do I need to do? And those are Black people. So the whole COVID-19 issue affects our community so much. And I'm listening to Mercy and I'm listening to all of you. And I think it's important that we think about this. Black people are just not one identity. And you know, Roberta, intersectionality. They're the same women who are facing gender violence. They're the same mothers with kids and parents. They are partners, they are friends. They are taking care of their parents. They're taking care of their grandparents and other family members. They have family members. I talk to my friends who tell me, I have family members who've been affected by COVID-19. I don't know what to do. And it is difficult. It's a very difficult time. I recognize that I have the privilege of working from home, of having, still having my income at this time. But then I have to think about everybody else. Right now in a refugee shelter, there's a lot of Black people who are refugees who have been tested positive for COVID-19. Nobody is even talking about that. Nobody's even addressing that. It's like Black people don't exist at all. There's people in limbo because they had yet to apply for refugee. They are yet to get OW. They can't get doctors to complete those forms. Ontario Welfare and ODSP says they have $100 of something that they can give people, but to get it, you have to call, have a registration number, have a computer. The whole bureaucracy of navigating those systems is already oppressive. People cannot navigate those systems. People living already in shared rooming houses cannot self-isolate. I work with people, men who are sharing a 2-bedroom apartment, 5, 6 people. They cannot physically distance. And a lot of them are working in factories. They're working in construction. That is the reality of Black people. So whatever the government is saying, whatever system is being put in place does not work for majority of our community. It does not protect majority of our community. It's not accessible to majority of our community members. There's still these parents who are at home who are supposed to be doing everything else and educating their children and homeschooling their children, yet they don't even have computers or internet, or do not know how to read and write, or don't speak English. But nobody is talking about these gaps that exist. This whole process is based on a certain class, a certain identity, but it's not our identity. And parents are facing so much challenges trying to even go, like I could, on my desktop computer, I actually have access to the TDSB files for several people's children, because I've had to walk parents through how to access homework and schoolwork from my house. I've done EI application and CERB application because people call and say, I don't know, how do I do this? But the agencies that are supposed to support people to do this work decided they don't have enough work for Black people to do from home during COVID-19. And unfortunately, that's the reality on the ground. And unfortunately, for some of us who call this out, we are putting our jobs at risk. But to all my friends going through this, I don't know. You're in my heart, I'm thinking about you. And it's just important to think that as Black people in the work environment, even without COVID-19, microaggression, misogyny, racism, underpayment, working harder than everybody else, always having to prove that you're supposed to be there and you deserve to be there and you deserve to be paid what you're getting paid, is an ongoing battle. Add COVID-19, it's a whole other battle. It's a whole other journey. And unless we do something, unless there's a one voice. A young man asked me a few weeks ago, what do we do about all these young men dying, getting into gun violence, all these challenges? And I said, you know, unless Black people create spaces for other Black people, we are on our own. We need to learn to create spaces. We need to be in those places. And this goes to what I think Beverly said and someone else said earlier there. We have to be in those spaces. And we can't be selfish in those spaces. We have to create those opportunities because we need the numbers in those places. Unless we stop being selfish and not building legacies, then the system, our children will go through the same thing we're going through today. Our grandchildren will go through the same things we're going through today. We need to create legacies. We need to bring our people to this table so that they can ask these questions. We can't have letters coming from the same 10 people. We can't have every time, it's crazy Beverly, oh, same. Oh, it's so sorry, she's always screaming at us. We can't have that situation. We have to create opportunities. We have to build opportunity. I told somebody that in Africa, when you employ your son and your brother and everything, they say you are nepotism. It's nepotism. Black people, what is it? African people, they are nepotistic and they are corrupt. In white people's country, it's called networking. So let's network. I'm done. Thank you.
Thanks so much, Maureen, for sharing your vast wealth of experiences and knowledge. I think the complexities of the impact of anti-Black racism and colonial violence, and also internalized racism or internalized anti-Black racism in our communities is critical to talk about. You know, your emotional feel for our people in our communities is so important to share, because this is about life and death for our communities. And when people are dying and when people are living in conditions that are so desperate and so in need, it's not about, you know, just having a conversation. It's not about being a Black elite. It's about really finding solutions for our community members. So I really want to thank you for sharing all of your experiences and your knowledge, and for empowering us to continue doing this resistance work. Dr. Anye Norum, if we could please share your thoughts in terms of service providers in COVID-19?
Hi, good evening. Thank you for having me. I just need a moment because I was like deeply moved by Maureen's statements, and they certainly struck a chord. So I actually like need a little bit of a moment, but to thank Maureen for her words. So thank you in that spirit of gratitude. Like, I'm here in Toronto. I'm very grateful to be on this land, and I'm grateful to you, the organizers, for having this, for Ray, for you, Roberta, and Françoise, and everybody who made this possible, and to all of you for tuning in. You know, just to kind of situate my own identity, so I'm half Nigerian, half Trinidadian, born here in Canada. I'm a mother, daughter, wife, family physician, as you mentioned, and public health specialist. And I'm actually very tired, as we all know, from carrying all of these identities, but I am here in solidarity. I also, I do need to correct something as far as my identity. Although I worked at Taibu Community Health Center for several years as a chronic disease lead, I'm no longer in that role. But I do wear a number of hats, and a lot of them focus on health equity and the impacts of anti-Black racism on health, as well as now working at the Center for Addiction and Mental Health around mental health, and actually podcast that you mentioned, Race, Health, and Happiness, about how we stay well in this very racialized world. You did mention the Black Physicians Association of Ontario. So I am president, and although I'm like not officially, I'm speaking on behalf of the entire Black Physicians Association. I am here in that role, in the sense that I am looking for feedback from the community that I can take back to the board. The Black Physicians Association is a small organization, but I do believe that the way our society is structured, the MD that is behind our names does allow us to have some privilege and some voice. And so many of our members have spoken out against the speech of the Chief Medical Officer of Health, Dr. David Williams. Listening to Maureen, what particularly pierced me is where she talked about colleagues, right? So I have the same training and background as Dr. David Williams, and as many of the people, the physicians working, or all of them actually working in public health. So this has been a really painful time when we think about Black health mattering or not mattering. Nonetheless, I'm also grateful for the voices like Angela Robertson and the Black CHC directors who wrote that statement that was read earlier and has circulated, Taibu Community Health Center, Black Health Alliance, and the Black Medical Student Association, as well as you, Roberta, and many others who are speaking out. And I too have spoken out against the decision not to collect race-based data. Specific to COVID-19, as you know, we've talked about here not having race-based data, but we know that African Americans are 2.8 times more likely to die from COVID-19. And this is not due to genetics. I know almost all of you know that, but I have to emphasize that as a physician, but they are due to the conditions in which African Americans live. And we know, which is due to systemic anti-Black racism. We also know that 68% of the healthcare workers who have died in the UK from COVID-19 were Black and racialized. And specifically, the first 10 doctors to die were all Black or racialized in the UK. So again, not due to genetics, but due to the conditions and circumstances in which Black and racialized healthcare professions live. I think sometimes we understandably think that those of us who have acquired a certain level of education or socioeconomic status are not experiencing disparities, but actually the data, at least from the US, shows that the higher you climb, the greater the disparities between yourself and your colleagues who have the same income or education. So as mentioned, we have no comprehensive race-based data for our patients, but I'm not going to repeat what was already said. We know the conditions in which we live, that anti-Black systemic racism affects us in multiple ways. Here in Canada, as highlighted by the United Nations, the Anti-Racism Directorate, and so many activists within Black communities, and as well as allies for some time now. So that has been spoken to very well by both Maureen, Dr. Bain, and Dr. Omishore. So I'm just going to kind of dive into the conditions for Black physicians right now. So I am not working frontline. I'm doing mental health calls on the phone through the Center for Addiction and Mental Health. But from the reports that I've gotten on the ground, Black physicians and residents right now are overworked and stressed out, particularly those working in the emergency or frontline. Some are fine, some are doing virtual clinics, to be honest. I myself am doing virtual clinics, but I think all of us, or many, the majority, particularly Black medical students in particular, are impacted by the social factors impacting our community. So we're all interconnected. So even if somebody has, crossed over to the other side of being in medicine, our mothers and our sisters and our brothers and our cousins and our neighborhoods are all experiencing this sinking of the ship. And so it impacts all of us in different ways, but the unemployment, underemployment issue of people having to work in many spaces, and also for us who are Black health providers, understanding that there are issues around health education and trying to also close that gap and to let people know that we are susceptible is creating a lot of angst and anxiety, not to mention the data that we know is coming from the US. Our patients are anxious, and our providers, although we're used to kind of just keep on moving, we are hearing that data from the UK, and we know what our social position is within healthcare. So in that light, I agree with Maureen. There are things that need to be done with those of us who are at tables. I myself am not at all of the different tables, but I can go back to the Black Physicians Association. I can go back to my colleagues and see how we can perhaps work in a collaborative way. And so what I've brought here is not solutions, I'm bringing questions. I know there's a chat line. My message is, and I know there are also allies on the line, so if you are a member of the Black community and you want us to amplify the work that you are doing, then please put it in the chat, let us know who you are. I'll bring that back to the board. If the board can't do it, then I as a physician can still try as a public health physician to amplify. Earlier it was talked about there are amazing things happening in communities to address these issues. I'd love to amplify that. But again, I can bring it to the board. If you are a member of the Black community and you have ideas of what we as the Black Physicians Association of Ontario can be doing, write it into the chat and I will also bring that to the board. And again, I can't promise on what the whole Black Physicians Association can or cannot do, but also I as a public health physician understand my privilege and my voice in being able to speak out and take action. So please send that. And even if you completely disagree with me or our position on the collection of race-based data, I welcome respectful but oppositional points of view, because that helps in thinking about how to mitigate the unintended consequences of the collection of race-based data, because it does come with consequences for our community if it's not used appropriately. And then finally, if you're not from the Black community, but consider yourself to be an ally, and I know those people are on the line, then if you are currently working on that active process of doing that hard work of examining your privilege and your power and not engaging in saviorism, then please also self-identify and let me know whether you would like to assist or support in different ways. And I'm hoping Françoise can give that to me offline after this session, but that is information that will be very helpful. What is not helpful though, is if you are non-Black and do not know what to do, but you'd like to be an ally and want guidance in that, I respect that, I celebrate that, but this is not the time. We are very tired and we are fighting for our lives as Black people and as Black professionals. So in a future time, happy to teach you and guide you along that process, but this is, at least in the notes to me, this is not that context. This is a pandemic, we are in an emergency. So I'm looking for those who are very much in line and ready for action or have ideas how we can take action. So I thank you so much and I'll stop there.
Thanks so much, Dr. Norum, for sharing and enlightening us on service providers' experiences, and especially about connecting the death of Black doctors during COVID and other health service providers. I think that's really important because I think the class divide happens within the community. I come from a working class background, I have a PhD, but I just finished paying my student loans, and I have family members who are migrant workers and who have been dealing with COVID already. So I think it's really important to talk about the issues of class and other areas within our work. There were some questions that were sent from the audience, the viewers, And I'd just like to share some of them, and maybe Maureen and Dr. Norum can speak to them, okay? The first question is, we are hearing about more and more frontline staff getting sick and dying from COVID-19, which you shared today with us. Frontline work is precarious and overwhelmingly gendered. Can you speak about the precarious employment and Black health amid COVID-19? You spoke a little bit about that already, but if you could share any more of your comments or your thoughts, that would be great. Maureen, perhaps?
Okay, so I'm here. So yeah, the reality is Black people that I know, who there's a lot of Black people who are immigrants and Black people who are here. There's a lot of Black people I know who are on Ontario Works or on ODSP. But they also substitute their income through working part-time jobs or side gigs, making hair, doing other things. And we know how much the money from the government for Ontario Works or ODSP is. And so because they cannot engage in those other jobs they do, or their side hustles that they engage in to make money on the side, like some babysit, they completely lose that other income, which is probably what's making them survive. And they don't qualify for the CARB. There's also a lot of Black people, and I could be very specific. I was talking to a colleague who said, I work a lot with people living with HIV. There's a lot of women living with HIV who work in as PSWs. And they work in different locations, in different places. A lot of them are still working. And one of the challenges that has been identified is that they feel like they don't want to negotiate not working at this time, because then they'll have to explain their health conditions. And then there's a stigma related to HIV, which becomes a challenge. So they are forced to work because of that fear. That's something to think about. And there's a lot of them. There's a lot who are working in those precarious positions where they're working part-time, different hours in different locations, running up from one place or another. And as of last, I don't know what will happen next week, because as we know, Doug Ford say no working in more than one place next week. I don't know what will happen. So there's a lot of precariousness. A lot of the other women that I work with, a lot of them from the Caribbean who are undocumented and have been living here for years and years, they've managed to survive even without the government support, from working in restaurants, from cleaning and other things. They can no longer do those jobs at the moment. The other issue is, although the government, and this is an important thing, and maybe goes to Onye too. So a few weeks ago, the government said, I do work a lot with people who are undocumented. I work a lot. I kind of distribute medication under the table and all this stuff. And 2 weeks ago, the government said that they've opened up healthcare for anybody, Ontario, to go and seek healthcare regardless of their immigration status. That's very beautiful on paper. We all know how healthcare centers work. It is very beautiful on paper. And so these already are communities that already know that going to a hospital is not an option, because you'll be given a bill of $10,000, $15,000. So they don't go to the hospitals. I don't think they're even getting the information from where they are, because they're not necessarily people who are watching the news and government policies that are being decided. But also the bureaucracy in hospitals, even if you went there today as undocumented with symptoms of, let's say, COVID-19, the first question they'll ask you is, where's your OHIP card or some form of insurance? The process of convincing hospitals, and we've had to have those conversations, that these people should be seen regardless of those status, we don't know. And that's why we need the race data. That's why we need this data collected, so we know if people are really being seen without status, as the government said. If people are not being seen, why? I actually told everybody that I know that if you go to hospital, call me. So I'll go with you so that I see if they will see you or not. But that's the reality. We know the bureaucracy in the health system. There are things that are announced on TV and are very nice on paper, but we know in reality on the ground, that is not the reality. But there's also medication. So what happens after you're seen? How do you access medication? We know pharmacare is not universal in Ontario. And for people without status, they have to work to buy their HIV medication every month. What happens now? So there's really a lot of challenges with people out here. And I don't know, there needs to be a conversation about how we support them. So for me, one is, how do we ensure the people who are undocumented, who are precariously insured, that includes people who have visitors visa, people who are international students, people who are migrant workers, and are in this country right now, are accessing healthcare when they need. That for me is a big question.
Thank you, Marie, and I think that's really important. I know during SARS and other health issues, the undocumented were always, it was important in terms of getting resources, right? Getting those resources, extra money to support people in terms of their health bills. And I think of thinking about also what you're talking about, different people working in different organizations. I mean, I worked 17 years in shelters, and I think different shelters and youth and women, I wouldn't have survived if I couldn't work in different organizations. So asking people to work in one organization is actually asking people to be bankrupt and not having money. So I think some of these are some of the serious issues that are happening in terms of our community and how it's managed and how it's worked. It's also about resources and about getting money in the hands of our community members and our people who are doing the work to actually get things done, because people are doing it on a daily basis right now out of own pockets, and they're not necessarily mentioned here, but we know who they are. We know what we have to do in terms of that kind of work. There's a question here that I think Dr. Norma might be able to answer. It is, I'm seeing a lot of skepticism with regard to the seriousness of COVID-19 and the perceived ulterior motives by Bill Gates, Big Pharma, and government with regard to a potential vaccine. What do you think is underlying this sentiment, and how do we navigate this public health risk? Dr. Norma, if you could talk about this.
Sorry, I had a problem with my phone. Can you repeat the question again? Definitely. Is it not being taken seriously? I missed part of it. I missed the critical.
I'll just read it again. I'm seeing a lot of skepticism with regard to the seriousness of COVID-19 and the perceived ulterior motives by Bill Gates, Big Pharma, and government with regard to a potential vaccine. What do you think is underlying this sentiment, and how do we navigate this public health risk?
So, I mean, there's a couple layers to that. So one is like misinformation, which has been an issue, particularly with regards to social media. So that's not specific to the Black community, but I think that becomes compounded in the Black community when you think about the fact that we have institutions that have historically treated us unfairly, right? And continue to do so, including healthcare. So we don't trust a lot of these different institutions because of our historical experience, and not just the intergenerational historical experience, but the lived experience of going into healthcare, like Dr. Dryden said, and people making assumptions about us. And so that trust is already breached. So when you do hear misinformation that aligns with your mistrust of, there's going to be a vaccine, et cetera, then that becomes amplified. There's also a history of us not being really incorporated into the general health discussion. So there's a lot of people who thought COVID-19 wouldn't even affect Black people. It was like a white people problem, right? Because of the way that a lot of these narratives go, we have to often see proof that something affects us too, because that's usually the narrative, right? When we hear about disease or certain conditions, we see a white face. And then, of course, there's the role of misinformation with regards to the fears about the vaccine. I've heard about, religion. There's a number of different things, but I feel like underlying all of that is a mistrust, which is actually very much a reasonable reaction when you think about how Black and other marginalized and minoritized communities have experienced healthcare and government, et cetera. So I don't know necessarily what the remedy is. I know that the Black Medical Student Association is working with the Toronto Anti-Black Racism Unit and the Black Health Alliance to engage in some myth busting. And so I've been in conversations with them, and we're going to explore how BPAO, or some of us as individual physicians, can help. Because where that trust is there, and us as Black physicians speak to kind of demystify, perhaps that will help. But we are still part of those systems. So I know from previous experience that there are also people who won't trust me, right? So I also appreciate that, because I'm part of those institutions. Even though I'm trying to disrupt, I'm still part of it. So it's a complex problem, but we can try.
Thank you so much, Dr. Norum. I think navigating the public health risk is dealing with anti-Black racism. in the system, in our policies, in our ideologies, in our practice. And I think you talked about it quite clearly. There's a question, though, the last question in this segment before we go on, in terms of medicine insecurities. I know for people who are dealing with different chronic health illnesses, myself with a visual disability, there's shortages in our medicine and being able to access them. The question is, are ASOs and other community organizations doing anything in terms of medicine insecurities? Is there a place or space where medicine can be, or resources can be given or are being given to people regarding medicine and not having their medicines? Maureen, if you could address this question, that would be great.
Yeah, so, and it's true. So I think as of last week, what happens, and for not just HIV, but for all other medications, the pharmacies are only dispensing a month's worth of medication to anybody and not more than that. And I think they're saying within 10 days of the end of your monthly prescription. So that's been kind of what's going on out there, and discussion about maybe perceived shortage of HIV medication and other medications over COVID-19. I think as of now, I don't think, apart from Toronto People with AIDS Foundation, which is probably just providing emergency medication, depending on what medication you're in, I don't think there's anything that's there at this moment. So maybe there will be more. I know there's a few pharmacies that do provide compassionate medication, but with a prescription from a doctor. So people need to be in touch with their doctors or wherever they are to get the prescriptions. And if you have someone who needs medication, just email me. I'll see what I'll do. I can't give a solution because I haven't seen one.
Right. Thanks, Maureen.
And realistically, Roberta, I think one of the things that we have to highlight that it's not just an issue of now.
Yeah.
On an ongoing basis, there's always been a lot of underground HIV medication movement where people contribute the medication they're not using to help those who don't have. Okay. I know because even now someone sent me an email and said, I have all this medication I want to give you. Yeah. But now that is also a problem because of social, physical distancing. Right. So those donations are not easy to come by at this moment without open space locations where people can go to and drop what they have or what they don't have. Right. So that's been the reality for a long time for a lot of people who don't have access to medication. But there's someone who asked a question, and I just want to address that why are there so many Black people undocumented? It's in the chat. There's a lot of links to that, but we have to understand, I think that's a whole other panel, to understand the context of how Black people come to Canada. It's not that people come here illegally. People come here legally, but somewhere along the line, people lose their status. There are women who get sponsored or partners who get sponsored, and because of violence, they separate from their partners. And before the sponsorship is through, so they do lose the sponsorship. There is people who come here as students, and after they finish school, they lose their visa, maybe because they couldn't afford tuition or other things, so they end up undocumented. There's immigrants. So there's a lot of reasons why people lose their status and end up undocumented in this country. And the disproportionate ways in which that being undocumented affects Black people is completely different from how it affects other races.
Right. Thanks, Maureen. I think it's important to mention also the immigration policies, right, they're not the same for us. And we know that our deportations of Black people and Black folks for many, many reasons based on anti-Black racism is something that we know in the community that often happens but is not talked about. So there are many reasons for that. I want to thank you so much, Maureen Orwino and Dr. Narone, for sharing your experiences, your knowledge regarding service providers, COVID-19, and before and after, and hopefully looking for some solutions. I'd like to send it back to Ray to discuss strategies and collective community response. Thank you so much.
Thank you, Roberta. Thank you, Dr. Norum. Thank you, Maureen. Lots of passion and lots of engaging on the panel. Before we move to this point, I'd be remiss if I did not bring up a key point around white supremacy, and it's directly connected to what we're talking about today. So one of our panelists who was scheduled to speak tonight who works for an agency, which I will not name, a public agency because she is a Black woman, was told that she was advised that she could not speak on this panel because of the nature of what we were talking about. And so this, and I've spoken to her about this, and I've talked about this with her, and that I was going to mention this. So Black folks are at risk, not only for their employment, you're right, but also for our voice. You're very right, Maureen. And so when you talk about, or when we talk about COVID-19 being connected to punishment processes, one of the ways in which we see the enacting of white supremacy is very clearly in the way in which Black folks, Black women are silenced in this narrative. And it's imperative, it's critically imperative, and this connects to what Dr. Norm was saying and what every panelist has said. It is critically imperative that not only that we uplift and support each other, but that we recognize and acknowledge that we literally are in a police state at war. We really are when it comes to Black lives and Black bodies. And that's hard for many people to comprehend and understand. Right? And so the rhetoric around, COVID-19 and why are we having a discussion about Black folks at the negation of other folks is nonsensical. It is directly connected to white supremacy and the ways in which that moves in and through our society, right? And so I just wanted to mention that because that unfortunate situation with our panelists really underscores and highlights exactly what we're talking about this evening. So having said that, let me move on to our last segment, which is about collective community response and strategies. And so we've asked each panelist to come up with 1 or 2 strategies or ideas that they have for a collective response, community response. And we'll start with you, Mercy. And after Mercy, if Dr. Dryden could go next. Mercy, are you there?
Yes, I'm here. So in terms of looking at community response, for me, I think I'm looking at how do we make sure that we are reaching out to people right now who have no access to technology, because for all the awareness that is coming out is going through, you have to have a phone, you have to have a way of connecting with social media. If people in the panel, attending these conversations have any ideas of when we are doing our community outreach and in terms of reaching to people out there, how we can go about this, because we put out, like a phone number where people can reach us, but that is through phone and that is through forms of social media and all those pieces. I know that OCRC is having like a round table to talk about immigrants and people without status and how we can continue working with them. And I know MCIS is having, trying to find different ways that they can provide interpretation services for people. However, my question is to the people who are participating in other ways that they may have, that we may be able to reach out to people and prevent, potential homicides for people going through domestic violence. And just to say that, I know shelters are full, but there are measures being put in place, such as trying to negotiate hotel spaces where if there is overflow, where we can put women. So right now we're trying to make sure that we do not turn people away. We are aware that a lot of people who've lost their frontline jobs or whatever jobs that they have are affecting our Black community, as a lot of panelists had mentioned. So we do know that there's a lot of intersectionality between all the different social determinants of health. And we do know that a lot of people facing violence are members from our community. So how do we let them know that there is help? How do we let them know that there is support out in the community?
Thank you. Dr. Dryden?
Hi there, thanks. So I wish there was somebody else from Nova Scotia on the call. May 1st will just be a year since I've been in Nova Scotia. And so I'm gonna talk a bit about what's currently happening as examples of what could happen. So immediately after the public health, the chief medical officer declared a public health emergency in Nova Scotia, the Health Association for African Canadians, HAWC, hosted a Zoom call in partnership with the Black Cultural Center that really focused on getting information out to African Nova Scotian communities. And so it was hosted by Hawk. It included Black physicians in the province, some who work in public health, some who work in, it'll come back to me. It's a late day here. And so 2 of those have happened already, and another one will happen next week. Kate McDonald, and I'm happy to share their email later, began COVID Cops. And so this is an online cop watch for Black, Indigenous, and people of color, QT BIPOC folks in Nova Scotia as a way to online document what is happening with the excessive policing and to make sure that that information isn't forgotten or rewritten. So and I think it's important, especially with the ways in which policing and public health have always gone hand in hand, that is also considered a health interruption. Elle Jones, who works in abolition and many other fantastic things, has really been leading the call for release. And so this abolitionist piece to make sure that people are released from jails and prisons, especially when we are seeing the ways in which simply by being incarcerated, we are not afforded any kind of living or life. And African Nova Scotian communities, and I don't necessarily want to name specific communities here, African Nova Scotian communities are working collaboratively to go door to door, to knock on doors, to share information, really have been pushing since January and February for an African Nova Scotian COVID pandemic response, one that actually takes into account the ways in which anti-Black racism happens. So then, and continuing responses to both the Premier and the Chief Medical Officer, demanding that they take accountability for the ways that they furthered racism or exacerbated racism, and folks holding space to insist that now, during the pandemic, is the time to address that racism. Unlike the Premier and the Chief Medical Officer, who keep saying now is not the time, not only to address specific concerns of Black people and African Nova Scotians, but even to address the racism that they're being called to account on. So those are just some examples of what's happened, what I'm aware of what's happening in Nova Scotia. But like I said, right, I'm new to the area, and there's a lot happening and some really great work because it's incumbent upon us to rely upon ourselves.
Thank you so much, Dr. Dryden. Beverly, we'll go to you next. Nope. Sorry, Beverly?
One of the things that concerns me right now is the changes that Doug Ford has actually just implemented, where he's actually now said that they'd be counting tests, is it? Right? As opposed to people who have been tested. So what you will find is if there are 4,000 people who are really infected, but they're only tested 1,000 people, then they will be counting a number of times that those persons have been retested to ensure that the virus has left their bodies. And that would be, and I think that is also a strategy on the provincial government's part to also be seen as being effective, but at the same time, also as a way to lower its count of what actually is happening in the province. Because it's actually skewing the data, if we think about it, in terms of who's really affected, who's being affected. So there's a whole population of people who are not going to be tested. I mean, he's saying that, he wants everybody tested, but we know that's not true. Everybody do not have access to testing. Just recently, just at the turn of COVID-19, Black mothers were taking their children and they were going to the hospital to be tested, and they were told that they had to come up with $500 if they wanted to be tested, and they were turned away from the emergency. At least these are conversations that were happening on the ground. People on the ground were being told by mothers and families that this was happening. So we know that Black people have been being turned away from being tested. We also know that this law is coming in, which would seem to also kind of project that he is actually proactive in testing everyone, and suddenly the numbers are dropping in terms of in terms of the virus itself. And I think this is also a real neoliberal move towards opening up the province, right? And to opening up the market. Because this is another piece I think people have to be very careful about. Give it another week and we're going to be hearing that they're talking about it's about time that we start putting people back to work like they're doing in the US under Trump. I do think that if we'll start to see a decrease in numbers, but we're not going to be sure what that means, right? And I think it's a move to move in line with what's happening in British Columbia. We don't know exactly how things are being counted everywhere, right? We don't have a clear sense of how data is being used and how they are actually operating in terms of using this data. And I think Ford is also being very, strategic in trying to reduce the rate of people who are infected by this virus without actually ensuring that people are being cared for in this province. Mm-hmm. And so one of the things I think we need to be really cognizant of is when we are hearing this information come out in terms of, is to find a way to hold up provincial leaders accountable around what does this mean for those whose lives are not being counted? What does this mean when Black folks ask and say that data needs to be collected that shows people based on race, how they're being affected? How do we know? How can we trust based on these kinds of moves that this is actually, it's actually reflective of what's happening? And I think because, we have moved to what has now become very much a very police controlled state, is that a lot of information has now become completely invisibilized to us. We are only told, but there's no way to see what's actually happening in terms of, the decisions that are being made. And this in itself is problematic. So we have to be proactive and and find a way to actually hold these people's feet to the fire in terms of what's going to happen to us. Because the thing that concerns me most is that we don't know what this would look like at the end of, of this pandemic. But what we do, or what we can actually say, is that certain people are going to be in a far worse position should they survive. And this would be primarily Black people on the front line, poor Blacks, homeless people, racialized, indigenous. These are people who are going to die, right? And they're going to die while the state find ways to actually create an appearance that things are getting better. Okay, when in fact they're not, right? So this is something that I think is really important. And the other thing that I think is really critical, that in talking every time that we think about data and we talk about collection of data, that we always keep in mind that this has to always be connected to policing. Like, we cannot speak about the collection of data around Black lives without talking about what it means in the context of policing.
Absolutely.
Right, that the two, the public and the medical aspect, or the issue of policing and medical health always have to be connected, because our lives and our health are impacted on both levels, right? Policing and surveillance and policing mechanisms and practices are health issues for Black people in this country. It's a health issue. It's also a life and death issue. It's a livability issue, and it's a futurity issue. And therefore, we have to keep it always connected. That would be my.
Absolutely. Thank you, Bev, and well said. And we know historically the narrative of sanitation and white nation settling has always been tied to bodies that are racialized. So incredibly well said. Thank you so much for that. I'm going to move on to Maureen.
Oh, thank you, Beverly. I think your points are very important, and the ways in, I think it's important to really think about the policing and the ways in which Black bodies are surveilled on an ongoing basis. Even as we ask for the data, the way that data will be collected from Black bodies is something we need to check, because that is also will be part of surveilling and might just be a whole other process of oppressing and practicing racism on Black people. And it's, I'm an optimist most times. Most times, I believe there's an ideal solution to a lot of things. And I think one of the things I've seen over the last few weeks is a lot of conversations among Black people about some of these issues, about how we collect data, because if we don't know how many of our PSWs are dying or getting infected, we cannot respond, and we cannot ask for we cannot ask for resources to respond. But I think we are resilient, and I hate the word resilient. If anyone who knows me here knows I hate the word. But we make it despite all the hurdles. And they've been, I believe, even on this conversation in our communities, there's a lot of expertise that can be leveraged to ensure this happens in ways that respect Black bodies, ways that privilege Black bodies, and in ways that really ensure that Black people are well taken care of, and equity lens and all those other pieces. I believe we have enough expertise for that in our communities. I believe if we leverage some of the people who've been in movements, whether it's queer movements, whether it's anti-policing movements, anti-prison movement in this country, from Nova Scotia to BC to Toronto, the activist scholars in our communities, we will be able to come up with a proper solution that benefits our communities. My fear is I will be fighting this battle, and my son will be fighting the same battle, and my grandchildren will be fighting the same battles. I need to be the only one in my family in this country as a first-generation immigrant fighting for this. I don't want to leave my kids fighting for this. As Black people, we work so hard for our families, for our children, for future generations. And so what do we leave the future generations of Black people here? What happens when there's a next pandemic? What happens? We won't be here. What happens? Will they be back on the table discussing the same things? At this time, I think we need to really put our heads together and make a decision for what's best for Black communities. And we can't do this in small groupings and classism and elitism and, you know, all these other things that are very colonial and colonial impacted, and how we've been colonized to the effect that we start creating these divisions in ourselves instead of working together. We have to work together. That's the only solution. Like, that's the only strategy. I don't know how that will happen, but I think we have to. We must. It's not have to, we must work together. We must leverage our elders and community leaders who've done this work before. And we must do this work so our children don't have to repeat this again. No, I'm done.
Thank you, Maureen. Always an impassionate response. And I think you're really speaking to many of the ways in which we organize and do our work. And I turn to Dr. Norum for the last word in this segment.
Thank you. I agree with the statements made. I think for me, I'll be brief because, you know, as I said, I came with questions rather than solutions because I want to hear from people as to what we can do. But I agree with the statements so far. I think that if we are successful in getting the data collected, then we need to be at the tables. Those are tricky spaces because I do know there are people of color or Black at these tables and they're not safe. And they're very few. So it's like, how do we make sure people are not just at the table, but understand how anti-Black racism works and also can speak out? So that's a delicate matter that I don't necessarily have the answer to. because I largely work outside those tables intentionally. So number one, how do we do that? Number two, where we work together. Yeah, like this is, we've got the internet, we've got social media. Is there a way for us to start reporting who is dying from coronavirus? Are we able to say, you know what, this was a Black or racialized PSW and the family has given us permission, let's put it on the websites. I know the first healthcare provider who has died from COVID-19 was a maintenance person. We know that poverty is racialized. I don't know for sure that this maintenance person was a racialized person, but there are pretty good odds they were. So is there a way to start to collect this ourselves until at the provincial level or national level, there is that understanding that this is necessary as far as a civil rights issue, as far as a human rights issue. But how do we, there's those of us who are physicians, there's those of us who are epidemiologists, there are those of us, I know some of you on the line who know how to do, mapping. Let's map it out, let's figure it out. So I think this might be cause for another conversation, but how do we do this online, social media, in a different way? So is that a possibility for those who have that background in activism and getting organized? That's my question.
Thank you so much, Dr. Norum. Thank you, all the panelists. So I'm saddened by the time because we do have to sign off, but I just want to just really quickly note a few of the things that have been happening by some folks who've been organizing in our communities. As Maureen mentioned, there are many people who are delivering groceries. There have been GoFundMe set up for sex workers. We have to also remember that trans folks are highly vulnerable when it comes to COVID-19. Black trans women experience violence 7 times the rate of their white counterparts and often highly marginalized. And so there's ongoing actions definitely that need to be taken. So just want to also mention that BLM, Black Lives Matter, they have launched a COVID-19 Black Emergency Support fundraiser through GoFundMe, and that's to help Black Canadians as well as other folks in the greater Toronto area. And so they have been working on ways to access food, to stay in touch with Black folks, and to respond to folks' needs. We've spoken about, Dr. Dryden mentioned, as I have mentioned in the beginning of our forum, particularly around decarceration measures, folks who are inside and who are being released, these folks are coming out with absolutely nothing. And when we're talking about Black health, we need to be viscerally mindful, and it's indelible that we remember that the impacts on those who are the most racialized, all of who we've spoken about tonight, right, are far reaching. And so we do have to close. So I want to give an incredible thank you to my co-host and organizer, Dr. Roberta Timothy. We have been organizing this and working furiously all week. And so, Roberta, it's been a pleasure to host with you and to put this together. And I want to send a very special thank you to each of our panelists. I've known many of you for a few years, and Beverly, we go way back. And so you've always been just an incredible warrior woman. And Maureen, I've worked with you, and we've also go way back. And so to Dr. Dryden and Dr. Norum, to Beverly and Maureen, and to Mercy, thank you so very much for sharing your time. And I want to just give a really special shout out to all the women, all the moms who are holding it down and doing this work, because there was a couple comments on the chat that said, shout out to the mothers who are, have their kids that are, mulling around us while we're doing the Zoom forum. So I just want to really acknowledge that and just acknowledge the work of Black women and the ancestors for really holding space with us this evening. So thank you so very much.
Hi, can you hear me now? Can you hear me?
Yep.
Oh, great. I just wanted to say that there's also a Black Lives Matter Nova Scotia fund that is collecting funds to support Black communities. So you mentioned the one in Toronto, but there is also one in Nova Scotia. And so if you hit me up on Twitter at JRJChair, I can share that link with you. Thank you
so much. I appreciate that. Thank you. Maureen? I'm sorry, Roberta?
Thank you so much to my co-host, Dr. Rai Reece, and to all the amazing panelists and viewers who continue to actualize change in our communities, for sharing your knowledge, experiences, and time. I do want to mention quickly, we haven't mentioned children in CAS and the impact of social distancing and not being allowed to see their children. And it's something that we would like to concentrate on when we do part 2 of this event. Also, in terms of the anti-racism directorate, it's in Ontario, and we need to have a national anti-racism, anti-Black racism directorate. Just in terms of ending, Black folks are not homogeneous. We have different genders, religions, ages, disabilities, chronic health, sexualities, sexual orientation, etc. And some more examples of important initiatives supporting Black health are the Black Creek Farm. They're making food insecure communities access free food baskets. Support them, give them money, give them volunteer. Community agencies such as Canada, Black Queer Youth, APA, EPA, and Women's Health and Women's Hands across boundaries are supporting our community members. To the nameless, but as important Black community members who are picking up food, buying food, paying rent for others, taking care of the sick, elders, children, we also see you, and thank you. Thank you to Dalla, Lana, Francoise, Obadiah for all your support and your technical wisdom. Stay well and stay safe. Take good care. Many blessings.
Thank you. Look out for part 2. Good night, folks. Thanks so much.
Good night.
All right. Thanks, everyone.